Good evening, warm welcome from AIG. Today we will be discussing in detail regarding the neuroendocrine tumors in gastroenteropancreatic region. So we have 4 talks and most 4 of them are very much experienced in their respective fields. So first I will introduce Dr. Sandeep Laktakia. He is the Director of Endoscopy and Endoscopic Ultrasound and he is the current President-elect of Society of Gastrointestinal Endoscopy of India. And for him, he has more than 160 publications in international and national index journals, and he received numerous awards like Fellowship of American Society of Gastrointestinal Endoscopy, Fellowship of American College of Gastroenterology, and also recently Fellowship of Japanese and Gastrointestinal Endoscopic Society in 2021. And he is the visiting professor to the University of Medicine, Myanmar since 2016. Welcome to Dr. Sandeep. Please go ahead, sir. So please unmute your.
Good afternoon, everybody, and good morning to Manoj. I'll be speaking on this topic of gastrointestinal pancreatic neuroendocrine tumor. In the seminar of diagnosis and management of NETs, I would be taking up the gastrointestinal GI perspectives and the recent advances in this field. So, if you see this slide, it shows this was published in 2008. It showed how the neuroendocrine tumors, which was formerly called as carcinoid, increased in numbers and in different areas of the body where neuroendocrine affects, starting from lung, which is the highest number, then the small bowel and the appendix. These are the ones which kept rising. Others are also rising too, but the major steep rise is seen in the lung, appendix, and the small bowel. If you also see at how the disease pattern evolves, whether they are localized or they're advanced or distant advanced metastasis, that also has changed. More and more of localized disease is being diagnosed, and that's mainly because of increase in the investigative patterns, which I'll touch upon in subsequent slides. Just for the background of the people who have joined, neuroendocrine tumors are the tumors which arise from enterochromaffin cells, and they occur throughout the body, and mostly they are reported in the GI and the respiratory tract. In GI tract, they mostly involve the rectum and the small bowel, and often they can be multifocal, especially in the small bowel. If you look at the that is about 2/3 of the patients or 60% would be in the GI tract, about 1/4 is in the lung, and about 15% in other sites. Among the GI side, the commonest is the rectum, followed by the small bowel, mainly jejunum and ileum, and then pancreas, stomach, colon, and thereafter. So this is the pattern of distribution in the different parts of the GI tract. Interestingly, they are usually asymptomatic and are detected incidentally. So you do investigations, be it in cross-sectional imaging or endoscopy or a colonoscopy for some other reason, and you find these lesions. And that's where the story starts to build up. Very rarely, they can present as symptoms, and the presentation can be with bowel obstruction or as obscure overt GI bleeding or occult GI bleeding, sometimes as bowel ischemia, and very rarely as a carcinoid syndrome. So based on their site-specific phenotype and behavior, the presentations can vary. For example, a lesion which is located large in the stomach or duodenum can present as an obstruction, which is not very usual, but more common is a bleeding. Also, the behavior depends on how, if they have a metastasis, local or regional or widespread metastasis. An interesting thing is these hormone-producing tumors produce peptide hormones, and based on which hormone the tumor is producing, the symptoms can vary. The commonest in this group is insulin-producing tumors, which are commonly from the pancreas, and they produce hypoglycemic symptoms in patients, which make them go to endocrinologists who treat them, and then with investigations for recurrent hypoglycemia, these tumors become evident. And sometimes they take long time because the index of suspicion is not so common. The classification of the GI nets, I'm sure Anuradha would touch upon it, so I'll just briefly touch in one slide. Were traditionally classified as well differentiated and poorly differentiated. In 2010, WHO further reclassified them as low grade and intermediate grade, calling as them G1 and G2. These are the conventional carcinoid tumors, and the grade 3 tumors are poorly differentiated nets, which are high grade, and they are also called as neuroendocrine carcinomas and have a poorer prognosis compared to the type 1 and type 2. Based on this grading of the tumors, the survival is assessed or prognosticated. So low grade have a very good survival, more than 10 years in majority. G2 have more than 5 years plus, and G3 are the ones which have a shorter lifespan. The oncological outcomes and treatment recommendations depend on the tumor grade of the NET, the site and the size where they're located, their depth of invasion, their growth characteristic, how rapidly they're progressing in size, and the extent of disease, whether they're resectable, metastasized, and so on and so forth. So incidentally detected lesions are on the rise, and there are several reasons for this. Very high quality cross-sectional imaging is getting available to more and more patients, and they are often found in patients who are going for investigation for some other reason and NET is found. Or if they're going for routine endoscopy and colonoscopy for some reason, or for a surveillance reason, we find these lesions. So the main reason for increased incidence of GI nets is basically because of improved and increased use of cross-sectional imaging and endoscopic techniques. Also, the physicians are now becoming more and more aware of it, and some and other factors are also being contributed, focused as the contributing factors, which are mainly proton pump inhibitors, which may cause the gastric or the duodenal NETs. Some environmental factors also have been implicated, but not cause and effect relationship is still not been established. Specialized imaging like CT and MR enterography also improve their ability to detect and find out how exactly they are behaving also. So the main prognostic factors in NET are based on their primary site and the staging. Also histological grading, and these the two highlighted ones are the thing which I will be covering here. So let me show you two scenarios that we often face. On left panel is a clinical scenario. Patient has a dyspeptic symptoms. He comes for endoscopy without any weight loss, but this is a prolonged symptom not improving with PPIs, and low with the vascularity on the surface on a sessile polypoidal lesion. So this is the common type of neuroendocrine tumor that we find in the upper GI tract. The second is a patient who has a CT scan for some other reason, and he is found to have these metastatic lesions, which were then confirmed to be a neuroendocrine tumors. Although he is asymptomatic from these two lesions, and he had no clue whatsoever of a disease which has so widespread, but they often can present as an asymptomatic patient as well. So these are several scenarios that can come, and these are two extremes which I just showed you here. Focusing to the GI aspect, on endoscopy, you can find very often these small sessile lesions, which are increased vascular, as you can see this vessels on top. So good endoscopy can sometimes give a clue. And these small lesions less than a centimeter in size can quite easily be removed safely. Because doing a biopsy of this lesion where the mucosa is smooth may not give an answer, and patient may go away with a non-specific histological diagnosis. So what we have to do is to go deeper inside and dissect the entire thing out. So whenever we see a lumps and bumps, we really don't know what's the G staging is, G1 or G2 or G3. And that's why it's worthwhile telling the patient that although you're asymptomatic, it's worthwhile removing this small tumor and subjecting it to histology. The other endoscopes, which have now improved also in their technology and their variety, are also helping us in diagnosis. So now we have a zoom facility where we can magnify any small lesion that we see in the GI tract. We can clean it up, and we can also do chromoendoscopy or virtual chromoendoscopy, which I'll touch upon later. And EOS also has added a huge impact on the diagnostic aspect as well as therapeutic aspect. It tells us how deep the lesion is going, whether we can safely remove this tumor, whether there are any lymph nodes adjacent to the primary lesion, which will make us think of other options in management. Let me show you some more examples. It's the same thing that we saw before in the previous slide. Now, if we do an endoscopic ultrasound, this is a mini probe in the duodenum. You can see this very tiny lesion. This would be about 5 to 6 millimeter. And we can actually see the layers of the GI tract. This black layer, for those who are not aware of it, is the muscularis propria layer, and the lesion is superficial to it. Any lesion which is superficial to the muscularis propria can be safely removed without any risk of perforation, even in the thin duodenum. And this can be removed by several techniques which I'll highlight. If you have a larger lesion like this in the pancreas or even the stomach, if you put a Doppler on this with the EUS, you'll see they are very vascular. So two things which are very important that EUS tells us is the vascularity as well as the layer of origin and the layers of involvement of the neuroendocrine, so-called neuroendocrine tumors, because we still do not have histology for it. And taking a biopsy may not give us right answer. That's why resection and subjecting it to histology will also tell us whether the base is free or the margins are free or not. So just to tell you more about the layers, these are the several 5 layers of the GI tract. The superficial layer is the mucosa, then there is a muscularis mucosa, then white one is a submucosa, deeper black is the muscularis propria, and the outermost is the adventitia or serosa. These are 5 layers. The lesions which are closer to the outer 2 layers have a high risk of perforation. Not that we are nowadays so much worried about perforation, because even if we cause perforation at the time of endoscopic resection, we can still seal it off endoscopically without subjecting the patient to surgery. So smaller lesions, we should try to remove endoscopically without getting worried too much. Having said that, all that we see, the lumps and bumps, are not all neuroendocrine tumors. There are several differential diagnoses, and each has its own way of appearance on endoscopy. So good endoscopy is mandatory to proceed further in the direction that we want to. For example, this polyp in the stomach is actually an hyperplastic polyp. These are multiple small nodules all over in the stomach, in the proximal stomach. These are funding gland polyp. This lesion, polypoid lesion in the antrum, is a pancreatic rest. This large lesion is a gist. And on the right panel is the neuroendocrine tumor. Sometimes they give us a clue on the endoscopic view. They will be flat, sessile in the stomach or duodenum, and often have an umbilication center which may be a little ulcerated or hyperemic. This is the appearance, classical appearance of a neuroendocrine tumor. We can throw some dye during endoscopy which will highlight the lesion or more, but often the surface of these lesions are quite normal, and that takes away from the usual mucosal polyps. These are actually submucosal lesions or subepithelial lesions as we call them, which may ulcerate and cause appearance towards some changes towards the mucosal side, but more often than not, they can have a smooth surface, and that's why the chromoendoscopy is not very helpful in diagnosing these lesions. Another example, this is the image enhanced endoscopy. This is the virtual chromoendoscopy or narrowband imaging as we call them. So this vascularity is a clue for this lesion being a neuroendocrine tumor, and we can magnify it more and you can see the vessels much more better, although the rest of the mucosal pattern is quite well preserved. So let's touch upon the different parts of the GI tract and the neuroendocrine tumors which are located in these one by one. So gastric entities are several types, type 1 to type 3. Type 1 is the commonest. 80% of these are type 1. They are often associated with atrophic gastritis, which can also be picked up by endoscopy if one looks carefully. They're usually multiple and very small in size. As you can see it here, there are several of them, often located in the fundus and the body of the stomach, and they're best left alone. Type 2 lesions also can be multiple, but they are associated with multiple endocrine neoplasia and ZES syndrome, where they have more acid production. Their size also is small, and they're also in the similar location. So the presence of atrophic gastritis and presence of high and low pH differentiates type 1 and type 2. whereas type 3 are larger lesions, single or one or two sporadic. They're usually big in size and usually in the fundus or the antrum. And these are the ones which are the dangerous ones. Let me show you a small video of how they look like. This is a type 1 lesion of small video that I showed before, the image I showed before. You can see multiple small ones here. And further looking into the same table now, so you will have increased gastrin level in type 1 and type 2, but the pH is increased only in type 1, whereas type 2, which has high gastrin levels, actually ends up causing low pH then. And the risk of metastasis and Ki67 levels are much lower in type 1. Type 2 also has a chance, but they're much lower, unlike type 3, which are usually single and large in size. The type 3 ones are the most dangerous ones, which have to be subject to resection. Type 1 and type 2, they're very few in number, can be removed endoscopically. And how do we remove them endoscopically? There are two major techniques by which we can remove. As you can see it here, this is one of the lesions which is being caught like a polyp. And you make it like a pedicle now, and then the pedicle is cut. Normally, the pedunculated polyps have a neck into it and which can be caught by a snare and cut. But since these polyps of neuroendocrine tumor are sessile, cutting them is little difficult. So we first strangulate them by applying a band at the neck of the polyp by sucking in a barrel band. And once we make a polypoidal projection of the sessile polyp, then we can strangulate and cut the neck of the polyp, which is then subjected to histology. The other technique is of endoscopic submucosal dissection, which is comparatively better because you get the entire histology. The difference between the two is that you actually do a surgical type of incision using various endoscopic tools. Here a knife is being used to circumferentially cut all around the polyp, including a small margin of the normal mucosa, which is marked before, and then it's cut layer by layer, and then finally the polyp is removed. If we happen to cause any perforation, that polyp area is then closed with the clips. This is the external or ex vivo image of the polyp. Moving forward from stomach to duodenum, there are several types of lesions in the neuroendocrine which can occur. Type 1 gastrinomas are common here, ZES or MEN seen in 1/3. Somatostatinoma is also described, which are usually in the peripheral region and can be seen in patients with von Reconstruct disease. The gangliocytic paraganglioma also are periampral lesions. They are benign despite the muscle property involvement. The type 4 is the non-functioning one, which are quite commonly seen in duodenum. And type 5, which is a purely differentiated carcinoma. So biopsy becomes important whenever we remove these polyps. Having said that, the majority of the polyps which we see in the duodenum are asymptomatic. Very few of them have ZES. Carcinoid syndrome is extremely uncommon, and hormonal symptoms are also very rare. Having said that, the distal lesions the proximal lesions are much more common than the distal lesions. So D1 has the maximum number of the neuroendocrine tumors, followed by D2, and D3 and D4 have much lesser number of them. If they happen to spread out, then the lymph nodes are involved first, which can be picked on DOTA scan or other scans, and even EUS can pick up perilesional lymph node. So these are the types of, this is the same lesion that we saw before. They have a very tiny whitish lesion, very sessile. Biopsy is going to be negative in this, or they can have a larger projection with an umbilication on the top, another one beside it, a smaller sister lesion which has an umbilication. This we've seen before. So this is an ampullary lesion, a large, like a polypoidal tumor. But if you do an EUS, you can actually make it out in the duodenal tube and it's bulging. It's large, hypoechoic or a dark lesion. And if you put a Doppler on top of it, they are very vascular. All the lesions which are on the surface and not invading the bile duct or the pancreatic duct or the pancreas, that is not going beyond the muscularis propria, can technically be removed endoscopically and subject to histology. Moving forward, in the small bowel, the other small bowel neuroendocrine tumors are much more common in the distal side, and they are the ones which present either with symptoms of the tumor or as carcinoid syndrome. And this is where the imaging comes most into play, because they are generally beyond the reach of common endoscopy and colonoscopy. And if you have a suspicion of neuroendocrine tumor, then a better cross-sectional imaging is advisable. And on the CT enterography or enteroclysis, you will see that these are hyper-enhancing nodular lesions. They are very, very vascular, so they will enhance in the arterial phase, or sometimes asymmetrical plaque-like thickening, like here, with the puckering and retraction of the bowel. As you can see it here, this is pulling the mesentery inside, and when this patient was operated, it looked like this, a whitish tumor which was puckered. These are some of the features of neuroendocrine tumor in small bowel on imaging, and also at the gross specimen during surgery. Some of the other lesions are a thickened asymmetrical wall, multiple lesions, or even in the appendix area. Majority are, 1/4 of them can be multifocal, especially those in the distal ileum, and early lymph node metastases are closely associated with the mesenteric vessels, and they spread towards the root of the mesentery, and that's why they cause puckering and scarring, and sometimes they present as obstruction. You can also find some of these lesions by enteroscopy if suspected. They present like an obscure overt GI bleed or an obscure occult GI bleed. This is a lesion which is seen here, seen on enteroscopy. Although it's usually an appearance, and again, biopsy may not give a clear-cut answer. Capsule endoscopy, other way to pick them up, you have some changes. There'll be whitish sessile lesions. Moving last to the rectum, these are small lesions and they can have varied presentation. They're usually in the third or the fourth layer, and they can have a gross polypoidal appearance which are much easier to remove than the sessile ones. So the predictive factors of metastasis is that the size, the hyperemic changes, and the surface ulceration of these lesions. Let me show you an example of a rectal neuroendocrine tumor which was removed by endoscopic resection. There's a very small tumor here, whitish. That's another clue. So you make a margin, a 5 millimeter margin on each side, and gradually keep cutting very patiently, layer by layer. And once we have a polyp-like projection in the center, then you can strangulate with a snare and cut it off. In case there is a perforation which can appear, not in this case, we can easily close with clips. And these are some of the publications which have shown the importance of endoscopic submucosal dissection for these foregut neuroendocrine tumors. Moving tangentially to the pancreas now, pancreatic neuroendocrine tumors are also increasingly being picked, and EOS now has an important role there. Also, it is used for localization and staging for FNA or FNB. It's an advanced imaging. Also, techniques can be used like contrast enhancements or fibroscan type things, and even interventions can be done, which I'll touch upon one by one. This is a very early publication in '92 where it showed the importance of EOS in neuroendocrine tumors. This came in NEGM way back. This is the classical appearance of how a neuroendocrine tumor looks like, very hypoechoic, round, well-defined, and they will be very vascular. It can also be very large in size and can have cystic projections, cystic areas of degeneration. And they are quite vascular, as you can see it here. This is a neuroendocrine tumor, and this is actually a patient of insulinoma. And we found this lesion, which was then ablated by EOS. And how do we ablate that? Just to make the audience in this group aware that endoscopically we can manage that. Having said that, there are now systematic review and meta-analysis which show the utility of EOS in pancreatic neuroendocrine tumors. FNA is standard of care. If you suspect a tumor or you see very vaguely, then you can do contrast enhancement and then light up very nicely on contrast enhancement. Confocal, other way of picking these lesions up. And if there is a insulinoma which has been picked up on EOS, sometimes if they go for surgery, the tumors are so small that they may not be found by the surgeon. So it's advisable to tattoo this tumor by India ink or by any other method, so that just before surgery, the surgeon can actually go exactly to the lesion, which saves the time during surgery. So how to ablate these tumors? There are two main techniques of ablating these tumors by ultrasound. One is injecting directly alcohol into it, which is a cheap way, a very efficient way of treating them. And other is a radio frequency ablation, which I'll touch upon. How does it work? So in radio frequency ablation, you pass the EUS probe, localize the lesion, and then pass a special needle type device which gives energy to the tumor, which burns the tumor under real-time vision, and then you just leave it off. It slowly liquefies and over a period of weeks to months may disappear or at least get scarred. This is our experience of ablating insulinomas in patients who are unfit for surgery. This is an insulinoma here, and we pass the electrode inside, and these bubbles tell us that energy is being delivered into the tumor. And once enough bubbles come in one area, we withdraw the needle and then go into other area which can then be ablated. So several areas can be punctured and heat, or the energy can be delivered there, and this all these lesions, the ablated areas and coalesce together, liquefy, and then the tumor then disappears. So this is how was the original tumor, and this is how it later looks like, a scarred one. One more example I would like to show here is a recent case of a neuroendocrine tumor which has again insulinoma very close to the portal vein and the pancreatic duct. They're very vascular, as you can see on Doppler on EUS. So seeing this vascularity and disappearance of that vascularity on during RFA will also tell us that the lesion has nicely been ablated. So here comes the needle device. The terminal part of the device is the one which gives the generation, the heat energy. Rest is all insulated till the top. And this is the bubbles which are coming inside. So we try to remain inside the margins of the lesion so that there is no risk of normal pancreas getting burnt, because pancreas, being a very thermosensitive organ, can cause pancreatitis. Moving forward, so why EUS for peanut ablation? This is a very provocative question, but I thought this is the right audience where I can impress upon people that because EUS gives a very good anatomical access to the pancreas, we can accurately position our devices inside the pancreas. It is safe, feasible, and very exciting branch. It's an expanded indication of EUS interventions and can be considered for patients who are ineligible for surgery. There are several publications now come from all over the world on using of RFA for not only for peanuts but other similar kind of tumors. The previous one was from Korea. This from France, multi-center study from France, and this is our own experience of only in insulinoma. There are 10 odd patients, 10 patients. This was published in the DDW 2020 of 10 patients with 13 lesions who had an RFA in one session in 8 patients. 2 patients had more than one session. Prophylactic stent was placed in 3 in the pancreas, and we have a follow-up almost of this was now more than 80 months of follow-up on all these patients. The largest is 80 months, and the youngest is about, in this series, would be about 24 months. But subsequent to that, we have done few more, and there is a very good biochemical resolution. The symptoms of hypoglycemia improves almost dramatically within 24 hours. They are euglycemic. Image resolution will take over a period of few weeks to months, and there are minimal complications. These are the biochemical parameters which improve. The insulin levels drop down, the C-peptide drops down, and the sugar becomes better. We expanded our indication to non-functional neuroendocrine tumors because the surgery is the standard of choice, but surgery has its own limitations. The risks of accepted risk of Whipple's procedure is 5% mortality and 50% complication rate, I think, which is quite high. To avoid such complications, I think we can attempt RFA in these patients, which is fairly safe. Although some complications have been reported, like pancreatitis, which can be prevented by putting a prophylactic pancreatic stent, especially the duct is falling in between, interposing in between the probe and the tumor. Or we can give indomethacin suppository, which is similar to what we use in ERCP prevention of pancreatitis. GI bleeds and perforation have also been reported, but can be prevented if one takes adequate precautions. In the end, I would like to conclude by saying that endoscopy, especially, and EUS, have a role in neuroendocrine tumors of the GI tract, especially in diagnosis, also helps in removal and in palliations of some of these tumors. Gastric NETs, if they are type 1 and type 2, need not be removed. Type 3 are the ones which require removal, and surgery is a mainstay because they have a high risk of malignancy in them. Duodenal NETs are generally small and can most need removal and can easily be done by endoscopy. Even if their perforation can be closed, rectal carcinoids or NETs can also be removed if they are reasonable in size. Most can be removed. It's only the small bowel tumors which require surgery because they can't reach very easily. Neuroendocrine tumors is an exciting field of US RFA, which can be considered in patients who are unfit for surgery. Thank you very much for your kindness.
Thank you, Dr. Sandeep, for a nice presentation to the role of endoscopic ultrasound. So if anyone have any question, please message in the chat box so that we can answer. Now I introduce my colleague, Dr. Mohan Roop, who will be introducing the next speaker.
Good afternoon, everyone. Now I invite Dr. Anuradha Shakaran. She is the Director and Chief of Pathology at our AIG Hospitals. She has over 2 decades of experience in entire diagnostic process and lab administration at our hospitals. To her name, she has more than 55 publications in index national and international journals and many book chapters. And she is the key reviewer for Indian Journal of Pathology and Microbiology. And she has many prizes to her name. One among them is the Gopal Rao Memorial Prize for being topper in her respective field. Over to you, madam. Please unmute, madam. Please unmute, madam.
Can you hear me?
Yes.
Good afternoon, everybody. Thank you, Mohan, for the kind introduction. So today I will be talking on the practical approach of neuroendocrine tumors, how we grade, how we stage, and what are the most common questions which the clinician expects from the pathologist. So, as you're aware that these neuroendocrine tumors arise from the cells which produce and secrete hormones. Dr. Sandeep has shown that the majority of the cases are from the GI tract and followed by the lung and pancreas. But what we have to remember is that all neuroendocrine tumors do not behave the same way. There is a subset of population of these neuroendocrine tumors which have uncertain behavior, and there are some which can have malignant potential. And the most common tumors which can have malignant potential are those which arise from the pancreas, colon, stomach, small intestine, and of course the liver. So what is the classification system for the neuroendocrine neoplasms of the digestive system that we need to expect in a pathology report? And does the category of neuroendocrine tumor grade 3 really exist? So classification is basically based on the function, the morphology, the site of the tumor, size of the tumor, extension of the primary tumor, and presence of metastasis. There have been a lot of classifications which have been revised from time to time, and currently recommended is the 2017 classification of pancreatic neuroendocrine neoplasms and the 2019 classification of the WHO for GI and the hepatobiliary organs. So initially there was only grade 1 and grade 2 well-differentiated neuroendocrine tumors, and there was the grade 3 poorly differentiated neuroendocrine carcinoma. Several studies have shown that the grade 3 neoplasms are morphologically well-differentiated with a proliferation index of greater than 20%. And these well-differentiated grade 3 neoplasms show better survival than the poorly differentiated grade 3 carcinomas, but definitely worse when compared to grade 2 neuroendocrine tumors. They show somatostatin receptor positivity, gallium positivity with associated possible FTG PEG positivity at the molecular level, and they have similar mutations similar to the well-differentiated grade 1 and grade 2 tumors. So what is a well-differentiated neuroendocrine tumor? That which shows a definitive neuroendocrine differentiation, which on morphology can have an insular pattern, trabecular pattern, rosetoid pattern, diffuse or glandular. The cells usually have a stippled chromatin and scant cytoplasm, and they are basically nests. And these, by definition, will be immunohistochemistry. They will show positive for synaptophysin and chromogram. And the poorly differentiated ones are those which lack any definitive morphology. They are in sheets, they are tightly packed, they do not have the stippled chromatin, there is atopia of the nucleus, prominent nucleoli, and they are further subdivided into small cell and large cell and are associated with extensive necrosis and have very aggressive behavior. So studies have shown that when compared to well-differentiated neuroendocrine tumor and poorly differentiated neuroendocrine carcinomas, well-differentiated tumors have a survival rate much better than the poorly differentiated. And this was also shown in those with ambiguous, whether they were well-differentiated to poorly differentiated. There was definitely a disease-specific survival of the well-differentiated cases. And this has led to the current 2017 and 19 classification, wherein they have given 3 grades of tumors, that is G1, G2, and G3, and they have separated the well-differentiated grade 3 from the poorly differentiated any neuroendocrine carcinomas, basically on the clinical history, the histomorphology, and the genetic evidence and prognostic differences. And this is particularly seen in pancreatic neuroendocrine tumors, where the poorly differentiated neuroendocrine carcinomas show the RB loss, P53 mutations, the DAX and ATRX mutations, and the MEN1 mutation. So when you compare the 2019 classification to the 2010, there is the new addition of the neuroendocrine tumor well-differentiated grade 3, which is not existing before. Similarly, there is this neuroendocrine tumor grade 3 well-differentiated in pancreatic neuroendocrine tumors, and these are morphologically and classically different from the poorly differentiated tumors, which I've already shown you on based on morphology. And then there is this new entity called the mixed neuroendocrine, non-neuroendocrine neoplasms, which were earlier labeled as mixed adenocarcinomas and neuroendocrine carcinomas. And this in the current GI tumors is abolished, particularly, but it is still recognized in gastric neuroendocrine tumors. So what is the significance of differentiating neuroendocrine carcinomas and neuroendocrine tumors? The key distinction is the grade 3 neuroendocrine tumors and neuroendocrine carcinomas differ with respect to response to platinum-containing chemotherapy, and patients with neuroendocrine carcinomas respond well to platinum-containing chemotherapy, whereas grade 3 neuroendocrine tumors fail to respond. And you have the symptomatic neuroendocrine tumors, which are symptomatic because they secrete a detectable level of hormones, and the symptoms are produced with the hormone overproduction, but they are slow growing, and morbidity is due to the hormone secretion. Asymptomatic neuroendocrine tumors do not have detectable hormones, and they do not cause any symptoms, but they are aggressive, and they are detected based on the tumor burden. So there are 2 types of neuroendocrine tumors: the functional neuroendocrine tumors and the non-functional neuroendocrine tumors. And this approach is not based on the IHC, but more on the serological activity and the consequent clinical manifestation. That means just because you have an IHC expression of gastrin is not sufficient to label that patient as gastrinoma unless the patient also displays classical functional features of gastrinoma, which Dr. Sandeep has just now elucidated. And another exception is the ampullary and the duodenal somatostatinomas, in which you will not have any measurable circulating levels of somatostatin, but definitely you have certain classic morphological features, which I will show you. The non-functioning tumors are not associated with any clinical hypersecretion, and they are incidentally detected or because of their large size or because of the metastasis to the adjacent organs. And these non-functioning pancreatic neuroendocrine tumors outnumber the functioning neuroendocrine tumors, and they are tumors with less than 5 mm are typically non-functional, and they can be classified as neuroendocrine microadenomas. So this is a 65-year-old male who presented mass and dilated CVD on endoscopy, and the PET finding showed a low-grade rotatate tracer with well-defined lesion diameter of 2.3 centimeters with dilated CVD and mild IHBRT with limited F18 PET uptake. An amplectomy was done. Amplectomy specimen was 4 centimeters and the tumor was around 2.5 centimeters. These are the microphotographs from the amplectomy specimen, wherein you can see the normal ampullary mucosa, and you have a tumor which is extending in the submucosa and onto the muscularis propria. Based on the morphology, It is showing a acinar and organoid pattern and residuoid pattern. That means it's well differentiated. But what we can also observe is you have some luminal proteinaceous secretions and pseudomatous calcified bodies, which are usually classically seen in somatostenomas. This case was positive for chromogranin, synaptophysin, and Ki-67 is only 2%. That means it's a grade 1 neuroendocrine tumor. And it is always recommended that we use an adequate pathology report to convey what we want to know to the clinician. And this report should have what is the size of the lesion, the extent of invasion, the dissection margins, any presence of lymphatic, venous, or perineural invasion. On the IHC front, whether it's positive for chromo, synapto, what are the number of mitosis on your hyper field, and what is your Ki-67 on IHC, and further classify it into well differentiated grade 1, grade 2, grade 3, or a poorly differentiated based on the morphology. So this particular case was a well differentiated neuroendocrine tumor grade 1 with the possibility of somatostatinoma, and the tumor was invading into the muscularis propria, and there was no regional lymph node involved. Now, from the pathology point of view, it's very important that we try to convey what is the grade and what is the type of tumor and what is the extent of tumor, because this will further decide whether the endoscopic dissection was enough or whether the patient needs to go for further surgical management. So how do you interpret a pathology report which says that it is a mixed neuroendocrine, non-neuroendocrine carcinoma? Now, mixed neuroendocrine and non-neuroendocrine neoplasms have been described with highest frequency in the colon, and as I already said, the earlier term was manic, which has now been replaced because this term does not adequately cover the heterogeneity of the possible combinations of the neuroendocrine tumor, that is, whether it's well differentiated or poorly differentiated, nor is it giving an adequate idea about what the non-neuroendocrine component is, which could be an adenocarcinoma, squamous cell carcinoma, or adenoma. Hence, the 2017-19 classifications have changed it into mixed neuroendocrine and non-neuroendocrine neoplasms. And these are neoplasms where you have substantially at least 30% of either category, both morphologically, and each component should be graded individually because they are usually each component are high grade. And even if you have a minor component of small cell neuroendocrine carcinoma, this should be definitely mentioned in the pathology report because of the possible response to platinum-based treatments. And the low grade, the mixed neuroendocrine, non-neuroendocrine neoplasms usually are a combination of adenoma and a well-differentiated neuroendocrine tumors. And these are called mixed adeno-neuroendocrine tumors. The intermediate grade tumors are those which are composed of adenocarcinoma and a well-differentiated neuroendocrine tumor. And the high-grade mixed tumors are those which usually have the poorly differentiated neuroendocrine carcinoma with an adenocarcinoma or a squamous cell carcinoma, particularly in the esophagus and the anal. And several studies have shown that the prognosis of these tumors is driven mostly by the neuroendocrine carcinomatous component, and because it is this component which often metastasizes. Now, why is grading so important in neuroendocrine tumors, and how reliable is Ki-67 evaluation on cytology of small tissue samples? So, grade is a major prognostic factor, and it is evaluated on the mitotic index of the HLE sections and on the Ki-67 index on the IHC. Ki-67 is a nucleoprotein which is expressed in the active phases of the cell cycle, and there's a lot of discordance in the grading by the mitosis on the HND and by the Ki-67 on IHC. So in 2017 and 19, there has been further modification of these gray zones because earlier the cutoff was G1 was up to 2% and G2 was 2 to 20%. So now there is a distinction that G1 is up to 3% and Ki-67 is less than 2 mitosis per 10 hyperfields. So if you see here, if you have a mitotic count of less than 2 and Ki of less than 3, it becomes a well-differentiated neuroendocrine tumor grade 1. A well-differentiated neuroendocrine tumor grade 2 is when you have a mitosis from 2 to 20 and a Ki-67 of 3 to 20. A well-differentiated NET grade 3 will have mitosis of more than 20 and a Ki-67 of greater than 20. Poorly differentiated neuroendocrine carcinomas, by definition, are always high grade. They're always grade 3. They have a mitotic count of more than 20 and they have a Ki-67 of greater than 20. So earlier, the number of cells which were recommended to be counted were around 2000, but in 2017 and 19, the suggested number of cells in which the mitosis should be assessed is now limited to 400 to 500 cells. But one point to consider is this is an eyeball estimation. It can be unreliable. There can be a lot of inter and intra-observer variation. And so, what do we do when this is such an important parameter based on which the grade of the tumor is going to differ, based on which the treatment is going to differ? So, you can use optimal methods like an automated machine or artificial intelligence modalities like your immunoratio, wherein you will capture the area of high Ki-67 and then come to an optimal Ki-67 one. Now, as Dr. Sandeep has already shown, that most of the cases of pancreatic neuroendocrine tumors or the GI tumors are first assessed by FNAC or FNAs. So, when we have limited tissues, the clinician should be aware that there can be a problem of distinguishing the grade 1 and grade 2 because of the smaller amounts of tissues which are available. To show an example, and also to mention that presence of ROSE, that is rapid onset evaluation, has increased the success rate of identifying these neuroendocrine tumors to as much as 100% when compared to 47% in the absence of cytopathology. This is a 30-year-old patient who had a history of recurrent hypoglycemia. He had a history of Men-1 syndrome, and he was shown a heterogeneous ecotexture with multiple SOLs in head and body, with largest around 18 into 15 mm. These are the pictures from the cytology, and if you see, you have cellular quadratic-cellular smears, which are monomorphic, which are plasma cytoid in appearance, and in the hyper view, you can see that they are focal areas of acinine and rosetoid appearance of the cells, and the cells have stippled chromatin. You do not have significant nuclear atypia or mitosis, or you do not have necrosis. So you can rule out for sure your ductal adenocarcinomas. The other differential diagnosis whenever you are dealing with the neuroendocrine tumors could be a stent, but of course the morphology does not fit here with the absence of papillae or any eosinophilic globules. And then the advantage of US, FNBC and FNB is you get a cell block, and this cell block you can do the IHC, and this is positive for pomegranate, and Ki-67 was around 2%. So this is a neuroendocrine tumor, well differentiated, grade 1. But I would like to highlight that sometimes there will be difficulty in interpreting Ki-67 because of the limited amount of the tissue. And then, is there a lot of intra and intertumoral heterogeneity in the grade of the tumors? And can the grade change between the sites and over time? And this is particularly very, very important when you are going to think of further treatment or keep the patient under observation or consider further therapy. So it has been shown that this heterogeneity is mainly because of multifocality and size of the tumor, and it's always advisable that we make an effort to evaluate Ki-67 in tumors which are larger, particularly choose the tumors which are more than 1 cm. And changes in grade can occur between primary and metastatic sites and between synchronous and metachronous metastasis. A recent study by Grillo et al. Showed that in 49 patients with metastatic gastroenteropancreatic neuroendocrine tumors showed a discrepancy in grade between sites in 39% of cases, especially in distant when compared to local regional metastasis. And studies have shown that there's a discordance between the primary and metastatic tumor, both with regard to increase and decrease of the grade when compared from the primary to metastatic sites. And if the pathologist is having access to both the primary and as well as the metastatic lesion at the same time, it is always advisable that we try to do a Ki-67 in the primary as well as in the metastatic site. And doing the Ki-67 in metastatic site is more informative to the clinician than the primary. And studies have shown that this increased grade in metastatic site is associated with lower progression-free survival and overall survival. So it's very important that the clinician is aware of the possibility of change of grade between sites over time, and thereby re-evaluate the grade whenever the patient has a known metastatic site. And what is the role of immunohistochemistry, and is it necessary that we should evaluate for somatostatin receptors on the neoplastic cells by IHC? Now, 5 somatostatin receptor subtypes have been identified, and the most important ones are the SSTR2A and B, because they are also transcripted by alternate splicing. And SSTR2A is the one which is most highly expressed. And what is the significance of evaluating these receptors? Expression of these two receptors on the membrane of the neoplastic cells is the rationale for using somatostatin analogs and the peptide receptor radionuclide therapy, particularly in well-differentiated neuroendocrine neoplasms. Of course, functional imaging with 68 gallium DOTA-TOF or DOTA-NOF and DOTA-T PET-CT is helping the in vivo evaluation of receptor expression, and IHC can be used as an alternative. And it has been shown that this SSTR2 expression is higher in the low-grade neuroendocrine neoplasms, and it reduces in the high-grade patients, both in the digestive as well as in the lung tumor. And expression of this is correlating with the prognosis, in that the well-differentiated neuroendocrine tumors, which have a high expression of SSTR2, are associated with longer overall survival. And one aspect which is very promising in the future is expression of SSTR5 may predict additional value of further newer molecules, and the identification of the truncated variant is associated with worse prognosis and low response to SSC. But the recommendation of the ECHO guidelines is for appropriate pathological diagnosis, morphological grading and IHC for chromogranule and synaptophysin should be reported, and SSTR staining or specific staining for peptide, hormones and amines and molecular markers can be optional and can be done only based on clinical requirements. How sensitive or specific are site of origin markers on IHC, like your TTF1, CDX2, etc. So when a patient comes with multiple liver nodes and FNE shows a well-differentiated neuroendocrine tumor, now the requirement is not only a diagnosis of the histotype and grade, but an indication of the origin as well. But one should remember that determining the origin of tumor by histological features alone is impossible. And the use of traditional markers like chromo and synapto do not indicate a specific crime. Then we can use alternative markers like CDX2, which is expressed in bowel neuroendocrine tumors, TTF expressed in lung tumors, and PAXA, ISL1 and PDX1 expressed with high sensitivity and specificity in pancreas. Poorly differentiated neuroendocrine tumors unfortunately do not express transcription factors with reliability, and therefore they cannot be used to identify origin. So CDX2 is expressed in ileal, colonic, appendiceal neuroendocrine neoplasms, and one should note that it is not expressed in NETs of gastric origin, lung, skin, ovary, though a minor percentage of pancreatic neuroendocrine tumors expresses. TTF1 shows 100% sensitivity for pulmonary NETs. PAX8 has a preferable positivity in pancreatic NETs as well as ISL. ISL1 is also expressed in 89% of glioma cases as well as in a minor of glioma. How should these immunopanels then be used to identify site of origin? If a patient IHC is showing strong and diffuse staining for CDX2 and negative for TTF1, ISL1 and PDX1, probably favors a midgut origin, ileal or appendiceal. If you have an IHC panel showing TTF1 negativity and negative CDX2 and positive ISL1 and PDX1, probably it's arising from pancreas. So in this way, you can use your markers to find where you have. But despite using multiple markers, the primary tumor detection is often challenging, and sometimes it requires clinical and appropriate radiological to come to a final diagnosis. Just your female with hyper-enhancing lesions in CT, and FNAC is done. FNAC is showing a tumor which is or morphologically suspicious of neuroendocrine tumor. Cell block confirms it with a classic organoid, trabecular, and rosetoid pattern, and then this is a metastatic deposits of image. So further, CDX2 and TTF negative, IMP3, ISL1 positive, and Ki is 5%. So that means it's a metastatic deposit from NET, well differentiated, grade 2, with possibility of primary from pancreas. Are there any other immunohistochemical prognostic markers for neuroendocrine tumors apart from Ki67? CK19 is shown to have an independent prognostic marker in pancreatic neuroendocrine tumors. Excluding insulinoma, expression of CK19 is associated with aggressive phenotype. Insulinoma-associated protein 1 or INSM1 correlates with malignant behavior. CKIT positivity has been shown to have adverse prognosis in pancreatic NET, and loss of expression of DAX and ATRX8A will have aggressive behavior in pancreatic NETs. What are the new therapeutic options for NETs, and what is the role of pathologists in these newer therapeutic options? So I would like to show it in the form of a case. A 61-year-old male had an ESD specimen done. Specimen was 1.1 into 1.2 centimeter with a raised area of 0.7 into 0.6 centimeters. The lesion is less than 0.1 centimeter from oral line and 0.2 centimeters from aboral line and 0.1 centimeter from the circumferential margin. So this was the specimen, and this is the raised nodule. This very well retrieved and pinned and marked. So the marking of oral and aboral line is very important. And these are the micro photographs where you can see a nice normal mucosa. These are the Brunner glands, and then you have the lesion which is rising from the submucosa, which is in insular and organoid pattern. There was no mucosal invasion, and this is the area which is showing the int margin, which is free. Synapse flow is positive, chromogranulin positive, Ki67 is very low, around 1%. So it is a well differentiated neuroendocrine tumor with a mitosis of 1 to 2 per 2 mm squared, no atypical mitosis. The lesion is free, is 500 micrometers away from the base. So the base is free, lateral margins are free. There are no lymphovascular emboli, there is no peritoneal invasion, there is no necrosis. So this was a case where there was complete resection of the tumor endoscopically, and so the patient need not go for further management. And as we are aware, that size plays a very important category, important feature in further prognostication of the patients. And the other ESMO guidelines are the disease stage by TNM classification are the most important prognostic parameters, and should be treatment of choice for low-grade NET 1-2. Presence of high-risk features based on the size or high grade should discourage an upfront surgical approach. And in the absence of any definitive predictive markers, therapeutic selection is often based on the clinical and pathological features. To summarize, a multidisciplinary approach for optimal patient management is the best way. And from the pathology point of view, one should use the latest 2019 classification, employ IHC for identifying the neuroendocrine nature, grade the tumor based on the Ki67 index, guard against overdiagnosis of tumors, always look for the two components and always grade the two components and give a proper TNM staging and the status after this. Thank you.
Thank you, madam, for the nice and detailed presentation on the pathology and recent updates in grading of GEP-NETs. Now I request Dr. Vamshi Krishna, Director and Head of Medical Oncology Division, to introduce the next speaker.
Good evening, everyone, and thank you. It's been a fascinating lecture so far. We saw the various presentations, and Dr. Sandeep showed us how you can do it, and followed by an excellent lecture on the pathology. And it is now my pleasure to welcome Dr. Manoj K. Jain as the next speaker. Dr. Manoj is the chair of the Division of Nuclear Medicine, the Department of Radiology at the Mayo Clinic in Florida. He is extensively involved in the nuclear medicine and molecular imaging. He has great experience in expanding molecular imaging practices over the past decade that includes PET scans, PET MRIs, and other imagings. Also, a very important role in the neuroendocrine theranostics, which includes the establishment of theranostic practice for neuroendocrine tumors using PET imaging and Lutathera therapy. Needless to say, several research grants and multiple peer-reviewed articles. I will not keep the audience from listening to him any longer. Dr. Manoj, over to you, please. Dr. Manoj? I think you're muted, Dr. Manoj. Can you just unmute yourself?
Now, can everybody hear me?
Yeah, we can hear you and we can see your slides.
I think this is a very common thing that happens with the virtual thing, that we are on mute and we keep talking. And it's early morning for me out here, so that's why I think it happened. But I would first like to thank Dr. Wamshi for this generous introduction, and would also like to thank Dr. Bachu and AIG Hospitals for arranging this webinar and making me a part of this. So without wasting any more time, I'll just start on the topic, which I think,
Dr.
some
Manoj, you are
introduction to this
presenting the
topic.
presenter view. Can you change it to slide mode?
Oh, sorry.
No problem.
Now it's good?
Yeah, now it's fine. Thank you.
Okay, great. Thanks. So before I start this presentation, I would like to thank Dr. Lakhia and Dr. Anuradha who gave such great talks. And I will be just adding on to their talks with the diagnostic role of nuclear medicine in gastroenteropancreatic neuroendocrine tumors. I do not have any disclosures, and I would acknowledge Dr. Tuba Candy, who is my colleague at Mayo Clinic in Rochester, and who helped me with some of these slides. This is going to be a clinical presentation, and I will be showing a bunch of cases and show how it has significantly impacted the diagnosis of neuroendocrine tumors. So nuclear medicine, so the main focus is going to be on somatostatin receptor and metabolic PET imaging in this talk. So which has significantly transformed the tumor, the management of these neuroendocrine. So this is one of our first patients that I'm going to show you a case in which we always talk about indium octreotide scans, which were done almost for the last 25 years. But now we are seeing that how much gallium dotatate imaging has improved our imaging and basically has improved our lives, because we see the tumors so much better. Otherwise, we were always questioning ourselves whether it's a real lesion or not, and we would see all this fuzziness. And I'll give you an example of that. This is an octreotide scan, and on which you see some subtle activity in the left side of the mediastinum, which even on SPECT imaging is just a fuzzy area of uptake. And 2 months later, when we got a gallium dotatate scan on this patient, you could see significant uptake, which is so nodular. This patient ended up getting a cardiac MRI, and you could see an enhancing lesion, which was an epidural neuroendocrine metastatic. So the learning objectives of this talk today include, we'll be talking about the physiological distribution and potential pitfalls of somatostatin receptor imaging, and also talk about the advantages of SSTR PET imaging over octreoscans scans, and the complementary role of SSTR PET and metabolic imaging. And I will briefly mention PRRT, which I have been involved since we started doing it in the US. And I know Dr. Paul is going to talk in detail about the therapy aspect of the neuroendocrine tumor, which would include lutetium dotatate. So there are multiple imaging techniques that we use, and anatomical techniques are still being used. And like Dr. Lakhia presented, the importance of endoscopic ultrasound, which really is very good for the local disease and the lymph nodes around the actual tumors. So the other thing, CT scans and MRIs are done routinely for both initial diagnosis as well as for restaging, and angiography for with both CT and MR has significantly impacted the visualization of lesions in the bowel. I will be talking mainly about the functional aspect of the imaging, which includes traditional octave scans, which I will just mention briefly. This is part of the somatostatin imaging. The PET tracers, there are multiple PET tracers that recently got approved in the US. The first one was the gallium dotatate, which was approved in 2016, followed by gallium dotatok, and now, more recently in 2020, there was approval of copper 64 dotatate that was approved. Dotanok is another tracer that is not currently FDA approved. So we have been using gallium 68 dotatate for all our stuff. For metabolic imaging, we have been using F18 FTG for the last 25 years. This will be important in poorly differentiated tumors. So these are the tracers that are FDA in the US. This slide is more for the trainees just to show how the activity you can see is in the. So on indium 111 octave conventional imaging, on the planar images, you can see the heart area are mainly the spleen and the kidneys, where most excretion of the tracer occurs. So similarly, in dotatate imaging, you will see the spleen being really high. We'll talk more about the physiological uptake in the upcoming slides. So it is important for the residents who don't know about dotatate and FTG. So the simplest way, if you get an image, look at the brain. If you see intense activity in the brain where all glucose metabolism happens, and in dotatate imaging, you will not see any activity. Cardiac uptake, you can see, can be very, is there in the most FTG scans that we do, but it can still be very variable. We have come across scans where you're not going to see any cardiac. So my suggestion would be always to differentiate between. So gallium dotatate, this was the first peptide radiotracer that was approved by FDA in the United States. It's a positron emitter. Interestingly, it's gallium 68 and its half-life is 68 minutes. So that's easy to remember for everyone. It is produced using a generator, and this generator is a germanium generator. The generator usually lasts anywhere from 9 months to a year based on the amount of use. And the other important thing about it is you do not need a cyclotron to make gallium or any of those analogs. So this is specifically, it targets overexpression of somatostatin receptor, which is most abundant in the neuroendocrine. The other important thing is that gallium, being a metal, needs a chelator or a linker to be attached to the peptide. And this is how it is attached to the peptide. And this complex finally attaches to the cells which target the surface receptors of subtype 2A cell membrane. Dr. Anuradha already mentioned that these are the receptors that are on the cell surface. Patient preparation for gallium dotatate imaging is very simple. So basically, patient doesn't need to fast. The only thing we need to make sure is the lanreotide or somatostatin receptors, because most of these patients are on treatment with somatostatin receptors, somatostatin analogs. So for short acting, you have to stop it for a day. For long acting, usually they are given every 4 weeks, and that is why it is important to make sure that the patient is not taking any long acting just because it can cause complications of the tracer. I would say mostly in clinical practice, we have noticed that after 2 weeks, usually we have not seen a significant difference. So if the patient is off for 2 weeks, we just go ahead and do it. So the dose for gallium dotatate is 5.4 millicuries given IV, and The uptake period is 50 to 60 minutes. Scan time from vertex to mid thigh, where almost every patient is scanned. It takes about 15. And now with the newer scanners, and depending on the size of the patient, we can come down to 10 minutes. Physiological distribution is another important part that we need to know about every tracer that we are going to use. If you are going to see that the highest tracer activity is spleen, and the other area that you see is the, because excretion takes place from the kidneys, and that is why it is very important for the patients to avoid as frequently as possible, especially in the first 20 minutes. Get rid of the tracer. The other areas of increased activity are in the adrenal glands, and then the pituitary gland, and the rest of the areas you can see. So this is another case which shows how, since somatostatin receptor PET imaging has started, and we have started seeing smaller and smaller. And multiple studies have demonstrated it. I don't need to mention it because it's now a proven fact. I don't think a lot of places are even using occultite scans at this point, because the availability of PET scanners and PET tracers has become so much. So this is a patient in which you see tiny foci, which are enhancing on CT scan. And on the same patient on octio scan, you don't see any uptake in the abdomen or the pelvic region. But this patient also underwent a SPECT CT, which increases the sensitivity and depth. But when you look at the gallium dotatate scan, you can already see the lesions being positive, see them being positive, exit on this scan. Like Dr. Anuradha mentioned about the Ki-67 index, and European Society already uses this to grade the tumor into low, intermediate, and high grade. And the importance of that is with low and intermediate grade, since they have more somatostatin receptors, that is the imaging modality that should be used for all those cases. And as the grade of the tumor increases and you start losing the somatostatin receptor, and in those cases, F18, FTG, PET CT, or the medical. So this is one of the cases that shows you that how a low-grade NET is negative on an FTG scan and positive on gallium. So this is a patient with carcinoid tumor who was on uptake therapy, stopped therapy 2 months before the FTG PET scan. So the patient got an FTG scan outside, and there were multiple lymph nodes seen in the upper abdomen, which did not show any metabolic activity. But this patient had, after a month, the patient had chromogranin A levels, which were increasing. A scan performed a month later showed multiple gallium dotatate avid lymph nodes. And the other interesting part, the same patient you can see shows ileal lesion, which, on the ileum you can see this lesion only on dotatate scan, but this does correlate with a subtle recency on the CT scan. But on the FTG scan done 2 months earlier, could not. So this shows that the well-differentiated tumors take the gallium. So a reverse case is seen in high-grade neuroendocrine tumors, in which you will have the poorly differentiated neuroendocrine tumor with high glycolytic activity, and they are metabolically active, and they are negative or shows very low level activity. This was biopsy, and the patient's Ki-67 was notified. Other important thing to understand is the differentiation, which is very important. So in the same patients, you can see both high grade differentiated neuroendocrine tumors. So this is one of them which helps in patient because if you only see one area, you might be misguided that either it's an indolent or well-differentiated tumor or a high-grade tumor. And in those cases, the treatment will change and in case there is expert. So if you take a section, this is a patient with pancreatic neuroendocrine tumor. And this is the pancreatic neuroendocrine tumor, and these are metastatic lesions within the liver, which when if you look at the green line, so this shows a gallium positive. And when the biopsy was done, it turned out to be a well-differentiated tumor because this area negative on FDG. But the actual tumor was poorly differentiated, and it was positive on FDG and no significance on the. So thus, we have to understand about the heterogeneity of the tumor. That in the same patient, you can have well-differentiated and poorly differentiated. Pitfalls, understanding pitfalls is very important in all these patients because physical activity, osteoclastic activity, inflammation, and other non-neuroendocrine or other types of somatostatin tumors can also happen. I'll just give you a couple of examples which are more important, especially splenials. Since splenic activity is so high, the splenials are going to have a lot of activity. In this example, you see underneath the spleen, you see this uptake, which is seen on the axial images, and this is splenic tissue, but they can easily be confused with peritoneal. The other thing is, especially in patients who have splenectomy, the confusion can be even more. And if there is splenic tissue in the tail of the pancreas, where we see it sometimes, and that can mimic a primary neuron. So the other important area is the uncinate process of the pancreas. In about 1/3 of the patients, you are going to see activity in the region of uncinate process of the pancreas. But definitely on the CT, you have to look at it carefully that there is no lesion. But if you look at this coronal PET image, you can see moderate level activity, which is third delirium in the region of the uncinate. If you have a nodular uptake and an intense uptake, which is greater than liver, then you have to consider, here you can see on the contrast that there is an enhancing of the other somatostatin receptor avid tumors can also show uptake. For some of the examples here of a pheochromocytoma, paraganglioma, medullary. One area that we all need to really look carefully is the liver. Since it has got so much of activity, what happens is a lot of time if proper windowing is not done, we are not region. That is why I would suggest that everybody should window the area of these uptake on any scan to see if there is something hiding behind that. And this is the same patient, and you can see so many metastases in the liver once properly. I think most nuclear radiologists understand that, but everybody needs to know that this is a very important part where we can mislead. This is one of the false negative cases just because the lesion was very small and peripheral in the liver, and liver having inherent increased activity can also cause these smaller regions to be seen. So if you look at the PET image, you don't clearly see a lesion because of the heterogeneity of the tracer, but incidentally, you do know ileal lesion, which was positive, and this was also positive. A neuroendocrine. The indications that we usually use are for initial staging once the diagnosis has been made, any mass that is unable to biopsy, and metastatic neuroendocrine tumor in which the primary is unknown. And before any major surgical intervention, we have to look for any additional metastatic disease which can change patient management. And also before PRRT to know. Renin score is another thing that we use and have it in all our reports, because the importance of that is if it is renin 3 or 4, those patients are likely suitable for PRRT. So in this, I just shown a case which shows that lymph node with intense activity, which is less than the liver but greater than the spleen. This is a great thing. Other tumors that can take up, and we have used some of these gallium dotatate imaging in some of these tumors. And one of them is the mesenchymal tumors. These tumors are usually small, and that's why we always do full body imaging. And these can also cause osteogenic osteomalacia. And this is one of the patients in which you see is retrocalcaneal lesion, which was removed. And these patients with mesenchymal tumors usually have the marker FGF23B being positive. And since these are elevated, and in most of these patients, once these tumors are removed, their markers come down to normal level. Multiple cell carcinoma is another indication in which we have used, and this was one of our patients who had significant disease. So since the patient did not have any other treatment options, we did try PRRT with one dose. And 1 month after the therapy, the patient showed excellent. But before the next therapy session, which is usually after 8 weeks, the patient had significantly, the disease had recovered. We gave another PRRT dose, but still the disease kept increasing. Multiple treatment options that we know. So we are going to just talk about lutetium dotatate briefly. So in this, usually what happens is, like on the cell membrane, you have the somatostatin receptors, the complex. So this is basically what I wanted to show was, instead of gallium, you just replace this with lutetium, and this is exactly how the lutetium peptide complex is. And this complex attaches to the cell surface, gets internalized, and once it is inside, then it gives beta radiation, basically destroys. It is a complex therapy, establishing and doing it properly to make the patient very comfortable. I think this is a whole interesting topic, how we worked on setting up the practice, but there are multiple departments. This was one of the patients in whom we gave additional therapy. So this is the first pre-PRRT scan. Between the first and the second scan, you can see there is significant improvement after 4 doses. After a year, there was recurrence of disease in the liver again, and we gave additional 2 doses, which did show some degree of activity. So this is one of the patients which we retreated with additional 2. So in conclusion, I just wanted to tell you that indium octide is no longer pretty much done in most centers, and gallium somatostatin receptor PET CT is being performed, which has superior accuracy, more sensitivity, faster acquisition, as well as lower radiation, and it is much more comfortable. AI67 is important to decide what tracer will be used at imaging. Tumor heterogeneity needs to be thought about while managing these patients. Also, liver is one area where we have to be very careful, because metastatic disease in liver is common, and overexpression of somatostatin receptor is important to know for success. Thank you.
Thank you, Dr. Manoj. That was a very, very enlightening lecture, and I'm sure there'll be a lot of questions from the audience as well. Thank you so much for joining us. I know it's very early morning for you, but thank you so much for joining us. It was a great lecture. Thank you so much.
Now it's no longer early.
You're all up wide and awake like the rest of us. Right. Dr. Sarita, over to you for
Yeah,
introducing the
thank
next
you,
speaker.
Dr. Manoj and Dr. Vamshi. Next, I will introduce Dr. Chandrasekhar Bal. He is a professor and head of the Nuclear Medicine Department at All Indian Institute of Medical Sciences, New Delhi. He is awarded Professor Majumdar Oration Award by Society of Nuclear Medicine India and R.D. Lele Oration by Association of Nuclear Medicine Physicians of India, and also Oration Award by the Indian Society of Thyroid Surgeons. Aims excellence in clinical research in 3 years, 2015, 17 and 19, and also EANM Springer Award in 2019 as a best published paper. And he has a special interest in therapies, especially radioiodine therapy in hyperthyroidism and thyroid cancer, PRRT, and also including actinium therapies. He recently published many papers on actinium therapy, so we are very interested to listen his talk on actinium therapy, his personal experience, and also he has experience in treating more than 12,000 thyroid cancer patients in his institute, and he had written more than 500 publications. Over to you, Dr. Bal.
Thank you. I think now can you hear me?
Yeah, we can hear you, sir.
Yeah. So can I start my slides or you are visible?
Yes, sir.
Yes.
Okay. Thank you. So thanks to AIG and my dear friends, younger ones, and now been in the field for last since I have been doing nuclear medicine for just last 4 decades, and my interest, everybody knows, is in the therapy, and I am a therapy guy. So I don't do nuclear cardiology. I don't do many things, but I do imaging of the brain, and my interest is in therapy. So the word theranostic, though it is very new, been practiced since 1942. The thyroid cancer and radioactive iodine are the organ of interest and the isotope of interest. And radioiodine is the first theranostic radiopharmaceutical that is ever used. And of course, the word was never used. So we used to do a diagnostic scan and then followed by therapy. If the surgeon has done a good job, we don't have to give any iodine, but if the surgeon has left something, so we give remnant ablation, we treat with nodes, we treat the lungs or bone metastasis if they are iodine concentrated. And this concept, which is now been formalized in 2004, published in Science calling the theranostics, and the concept is very simple. See, treat and confirm that what you have treated is okay, and now you can do dosimetry, you can have a target, you can design the probes, and the probes are very specific. So unlike in chemotherapy where it is a carpet bombing, in nuclear medicine we have got targeted destruction. And we can use a missile like beta, which has got radiation weighting factor 1, and we can go up to high alpha, which has got radiation weighting factor 2. But you know now for last 20 years, the radiotherapists are very much happy in putting the proton therapy, which has got radiation weighting factor earlier in 1990 it was 5, and in 2007 it has been reduced to 2. That's why a lot of interest has been reduced in the field of proton therapy, and compared to alpha, which has got 20. So we are starting from the beta, then we move to alpha, and you can imagine anything that you can put a nuclear warhead in any missile. That missile can be short range, can be long range, can be designed properly, and you can have a linker, you can have all this has been told by Dr. Manoj very nicely, and that I am not going to take much of time. So what is PRRT? We need the radiopharmaceutical, which are the probes, and attached to it is the weapon. So what if we put a gallium or a indium, we can see the image, and then we replace the missile, is a conventional missile with a nuclear warhead, that is a lutetium-177, yttrium-90, or now actinium, or you can put lead-212 and many radium-2 and 223. All these are been in the now. When I was a nuclear medicine student in 1988, I never thought in my lifetime I will be able to use alpha. And here we are in the leading front. And last June, the Society of Nuclear Medicine awarded us, giving the 2021 Henry Wagner's Award for the best research of the year. So that's what we have come from. In 30 years, we have started from the nowhere, we have reached to the stage by using all these missiles. which is, you can see that the availability of doing the somatostatin receptor imaging in Europe is 20 years. In India, since 2008, it is at least 14 years, and the US in 2018 onwards. You can see how we are at least a decade ahead of current American experience. Then you can have, this is the international guideline, and this is the PRRT published way back in 2011, and you can see that is the contribution by us. So in 2011, we have the Americans and the there are only Tom and his wife who are the only members from the US, and rest is all Europeans, and I was the only rest of the world. Rest of the, they say in Western world, the rest of the world. So the rest of the world is represented by me, and we had written way back in 2011 this guideline. And as you can see in 2018, just a very famous paper, you can since 1973 to 2004 is almost 40 years. There was the median survival rate has not changed much. What has changed is the distant mates, where some improvement in the median survival rate since 1973 possible because of the improved diagnostic and monitoring techniques. And still there is not a very good. Whenever there is a plethora of treatment options available, that means none is suitable. None is they say they are running in the same parallel. So which you can choose depending on your expertise, availability, and all this. So this is not the good scenario for the neuroendocrine tumor. So what we started with the yttrium-90, which is a very good it's a radionuclide, but it has got long 12 millimeter range. But if your tumor is big, it is good, but it will not able to treat the smaller tumors. If you have got micronodules in the lungs, one side, that drawback. The other drawback is because of the larger depth penetration, so it will do renal kidney damages, and that was what the initial experience from the Basel had produced so many renal failures, which is discouraged yttrium-90. But what happened in the meantime, India forefront of the lutetium development, and Dr. M.R. Pillai and Dr. Ramurthy pushed the lutetium-177. Lutetium-177 has got is tipped as the metallic iodine equivalent. It is metallic iodine of modern era. So it has got a very nice beta, which is equivalent to same as iodine. It has got E beta max of 497, average around same as iodine. You have got two suitable gamma, which is 113 6% and 208 11%, which you can do nice dosimetry, imaging, post therapy scan confirmation. All these are beauty of lutetium. So now in the era, the lutetium has really taken over all these interesting. What I was talking, indium started with as a Krenning started indium octreotide, which has got a micrometer. So you can only treat very, and hardly it has got any response in forms of objective response rate. But yttrium-90 has 12 millimeter, while lutetium has got a beta max range of 2 millimeter, which is very suitable for all this imaging. Then you can see till 2004, we had only 3 countries: Rotterdam, and Basel, Milan, and only New Orleans. Dr. Su and Tom used to do some yttrium indium level. You can see this till 2004, as late as 2004, there are only 3, 4, 5 countries used to do therapy. Coming to the molecular radionuclide therapy, which we are going to talk about, is the patient selection by SSTR expressing tumors, choice of peptide and radionuclides, kidney protection using the positive amino acids lysine or arginine, or you can use in Germans like they use gelofuscin. Tumor and organ dosimetry is a must. Monitoring of the toxicity is a must. Clinical results and future direction. I will be going to give my talk in that sense. Coming to the somatostatin receptor, which is native somatostatin is 28, and we have got somatostatin native 14, then it modified by the Krenning. Then you have got the Sandoz company. Now the Sandoz company has been 2-3 times sold. Finally, it is now with Novartis. It is octreotide, and these 4 amino acids at the core, they are called domain amino acids. They bind to the domain structure, and what you need a hairpin loop. So there is 2 cysteines, which is disulfide bond then makes. So you can replace We know, interestingly, the amino acid is L amino acid and sugar is D sugar. So this L amino acid, if you replace by the D amino acid, our enzymes are tuned to, like somebody is a lefty, he will not able to use right hand properly. But somebody is right-handed, he will hardly use left. So here, what has happened? If you replace a L amino acid with a D amino acid, the enzymatic cleavage will be slow, but eventually the body will take care of that. So you increase from 1 minute biological half-life of the somatostatin to 3 to 4 hours half-life with octreotide. So you can give 8-hourly octreotide injection, and there is a small molecule you can change for your patent. To avoid the patent, you can change any of these small molecules with keeping this same loop, and you can change lanreotide, vaporeotide, and all these, but you have to maintain this hairpin loop. So now this protein, this peptide can be labeled at the end. There is a hairpin at the tip. You can attach a bifunctional chelate, and we started with DTPA, which is a linearized bifunctional chelate, but it was not good because you can attach larger heavy metals. You need larger pocket size. You need stronger binding. You don't want your metal to be chelated out. So you can place with gallium, you can place with indium, yttrium, lutetium, and the number one that is popular among all is NOTA and DOTA. Then we have got the NOTA, TETA, PENTA, all these DOTAM. Now the recent one is DOTAM. All these are bifunctional chelate which are away from the domain structure. So the biological activity is maintained, and the non-bonded interaction or van der Waals interaction is away from this. And this cage is very strong. So we have now improved the radio or the probe. Now we have got suitable radionuclides. So what we have to now we are getting, this is the imaging, which never used to see such beautiful, nice images. You can see the treatment decision based on gallium somatostatin receptor PET CT is now the current, not the octreoscan, which was indium based. It's poor quality image. Now you can see all these gallium based PET scans, very nice, suitable, and people are trying to how to improve it further using fluorine 18 and all this research going on. So then coming to the protocols, the technical details available free of cost from IA website is this book is free downloadable, has to be done in the hands of experts. Systemic IV infusion, supportive care with basic amino acid infusion has to, because whenever you give positive amino acid, there is a possibility of the nausea. So you have to prevent that by giving preventive antiemetics. And the schedule evolving from over 6 to 12 weeks. We don't know exactly how many. And the NETR trial has made it 8 weekly, but people use 6 weekly. Some people say 12 weekly, and some even now proposing, because it's a slow growing tumor, why you want to give so rapidly? You can wait for 6 months. But these are all the protocols. Once it is approved by the FDA, so it is now 8 weeks, 4 cycles. Then coming to the side effects, overall very well tolerated. Then you can have acute fatigue. Usually after the radionuclide therapy for 25 to 48 hours, you can have fatigue, nausea, vomiting, cytopenias, rarely renal insufficiency using lutetium, myelodysplastic syndrome. Occasionally you can see, I can come to that in the latter part of my talk. Liver toxicity, if there is a heavy liver burden and hardly any healthy liver tissue, possibility of liver cell failure or crisis, you must carcinoid crisis, you must be careful about it. And then coming to each somatostatin receptor based PRRT fit for all GEP-NET patients, the answer is like this. And Dr. Manoj also showed very nice carcinoma. You can take it out. There is no need of any PRRT. In such patient, you made the diagnosis. You demonstrated there is most of the carcinoma at the time of diagnosis has already metastatized. But here is a patient which has got a carcinoma, but it's not at metastatized. So you can treat them by surgery, and they have the best outcome. They are the best outcome. Surgery is the best outcome still today. And then coming to this patient, where we did a gallium totanox scan, it is not showing pickup, but you can see the FDG. So this is from the in vivo immunohistochemistry, we can say that this is a grade 3 NET. So this is what FDG positivity, NOTA negativity, grade 3 high, Ki67 will be there. So such patient, they don't need PRRT. Look at this patient, which has got unknown primary site hepatic mets and sky high raised serotonin level. So you suspect this could be a carcinoid syndrome. And you can see we did the left hand side, you can see the F-DOPA, the right hand side is gallium. Again, you see F-DOPA picked up much more lesions than gallium. So it is not that one isotope or one tracer will give all the answers. It is not, but you can schedule them. You can properly know which patient is going to be benefited by which tracer. Look at this patient, which has got very rapid, this is 56-year-old male with hepatic metastasis, F-DOPA negative. You can DOPA has got a biological signal. You can see the basal ganglia in the head. So these are the diagnoses written in the head. So here you see a pituitary. So the diagnosis, so-called biodistribution. So these are the signature of the tracer. So you know which tracer is what. You can see the spleen, you can see the pituitary, you know this is a octreotide, and this is fluorodopa. You can see fluorodopa is not showing whereas gallium dotanox. So this patient can be gone for. This is a pancreatic net, and this is non-secreting, of course. So this has got a gallium dotanox positive and insulin. And coming to another patient, look at this another patient which has got a metastatic insulinoma. All fluorodopa showing is a huge amount of uptake, whereas gallium dotanox hardly anything. So they complement each other. Unfortunately, we don't have any counterpart for fluorine-based peptide therapy or fluorine-based radionuclide which can be treated. So theranostic factor, dotanox has got a theranostic partner, but F-DOPA doesn't have a theranostic. It's similar as FDG. Doesn't have a theranostic partner. So that is the one area of research which needs to be done. Then they coming to this patient, initially diagnosed as small cell lung cancer, given 6 cycles of chemotherapy, no response. Path review, G2-NET, confirmed by SSTR. Look at the gallium dotanox PET scan. We can pick up this very well, and we treated with a lady with this is FDG also very little, and you can see the treatment, and already patient has a metastasis there. So you can see the head and neck metastasis, which is now picked up by the lutetium dotatate. So you have to properly map out what are the sites which have been metastatized, how the patient going to manage. If it can be operable, you should remove it. And then you selection of the patient what must be known before is as follows. The histology showing the Ki proliferation index, or in US they talk about the mitotic index, and the transatlantic divide. The Europeans talk about Ki67 and Americans talk about the mitotic index, but they are talking the same thing. They are like two blind men going to look for the elephant. So they are talking the same thing. One is by immunology, another is counting by your eyes. And then you have got promogranin, synaptophysin, hormone production. So whether it is a producing glucagonoma, you can see, look at the patient, you can make the diagnosis. Insulinoma will have hypoglycemic insulin, hyperinsulinic hypoglycemia. Gastrinoma will have some symptoms, hyperacidity, receptor density, which is must before treating the patients. Then another important thing is measuring the glomerular filtration, because the renal failure possibility is there. So you should not produce the renal failure in this patient. At least your GFR should be more than 60 ml per minute per 1.73 per meter. Your blood profile and chemistry, like all this, has to be in the acceptable limit. And then coming to the look at this treatment. We do a dual tracer imaging. FDG PET scan is negative, and you can see the gallium dotanox positive. We treated with lutetium. So this is how our paradigm at institute. And if patient has already, many a time the patient comes to us with already a FDG scan done, so we don't have to repeat that. So we do a gallium scan, and then we plan for the schedule for the patient treatment. Then we can have look at this patient which has got this treated. I treated this patient way back on the 10th of October 2008, something 14 years back. And you can see the tumors. The patient survived about 8 years, and finally he succumbed, he progressed and died, and had a stable disease for many, many years. So we can get also the patient now. Some patients, very rarely we get complete remission, and you can see this patient is near complete remission, but still we have one lesion left, and there is near complete remission. We didn't get anything like that. So coming, kidney is the critical organ for PRRT. The radiation dose threshold for organ has been extrapolated from the experience of EBRT, and the EBRT has set the dose limit 23 gray to the kidneys, and which is probably, we think this is 5% injury to the kidney in 5 years, which is not reasonably. We have seen now, even we have got 35 gray, still kidneys are protected, and we need long term. We have now 14 years of experience treating these patients. We are following this cohort. Now we have got large data, volume of data. Individual renal absolute dose measurement thus play a pivotal role for kidney as the critical organ in the therapy. And then coming to the, you can do all the dosimetry, then protect the kidney by giving positive amino acids. And it has been shown that 62% of the kidney protection can be done with the basic amino acid infusion. We did the dosimetry, and one of my PhD student way back, he did the thesis, and we published it saying that dosimetry of lutetium dosimetry is safe and protective, and it can be also published in CRB. We have seen all this. Then coming to the latest modern era, what has happened all these years? We have a phase 3 clinical trial, which is the landmark. And you know, in lutetium PSMA, we took 5 years to have a vision trial. And NETR1 trial took 18 years to be completed. So that's why the starting initial hesitation. Then there was no big pharma company we thought that we can make money. Finally, Novartis supported this, and they come out with the NETR trial. And once they test the blood, they know that is money coming from the therapy. So now they manage the vision trial, and vision trial got approved in 18 months time. And now everybody is gaga about, because the neuroendocrine tumor constitute only a very small fraction of the total cancer burden, which is about 1%. Whereas prostate cancer is the big boys club. There are 4 permanent member of, like 5 here in 4 permanent member of the cancers. They are breast cancer, prostate cancer, colorectal cancer, and lung cancer. They are the 4 killers. And if you have your hand on pie of the only one of them, your day is made. So that's why the NETR trial took 18 years, and vision trial took only 18 months to complete and finished. And it is even before the publication in New England Journal, the FDA approval got. Because prostate is a big organ, and money is coming in all left, right, center from all angles. So that is why the pharma companies are pushing up this product, and we are happy for that. All these years I was thinking that we will be always in the sideline, and now we are in the main focus. The neuroendocrine tumor NETR1 had is a phase 3 randomized control trial supported by Novartis. The primary endpoint was progression-free survival. The secondary endpoints were objective response rate, overall survival, safety, and side effects. Then the 2 arms. In one arm, they give 200 millicurie of dotatate 80 weekly interval, and in the meantime, they also give 30 milligram 8 weekly, then subsequently 4 weekly. And the control arm had LAR 60 milligram every 4 weeks, but there was an option they can shift to the control arm, people can shift to the intervention arm. So this is the total flow chart. I don't want to go in details. There are 231 patients. This is the intention to treat analysis. 117 were in the lutetium arm, allotted to 117 in lutetium arm, 114 in the intervention in the octreotide arm, and then 6 people did not look, and here 3 also did not. So we have finally 111 people received the lutetium dotatate, and 112 people were in the control. So what happened after 20 months of follow-up, the PFS, they wanted to get the immediately result published. They didn't wait for the long term. They, even after 20 months of result, we have got PFS 65.2% patient achieved PFS, whereas control arm only 10.6, which is statistical significance. Overall survival in terms of interim death occurred in 14 death in the lutetium arm and 26 death in the control arm. Overall response rate was 18%. Out of that, only 1% achieved complete remission, remaining 17% was partial remission, whereas the partial remission in 3% in the control arm. And there was neutropenia in 1%, thrombocytopenia 2%, lymphocyte. If you compare against the chemotherapy, this is a golden era. If you compare with the chemotherapy, this is the toxicity is nothing. And the medical oncologist will be accepted, saying that, oh my God, you have got only 1% neutropenia. Every chemotherapy guy is scared of, morbidly scared of the neutropenia. And this is what the selection of 101 patient, they published that data. One patient had complete remission, 17 patient had partial remission, and total 18%, because the number was 100, so the number and the percentage almost same. And then you had in oncology, you can see always these two curves, they will go about 2 millimeter parallel to each other. But in this sky high raised intervention versus control, you can see in nuclear medicine therapy arms. And this was the beauty of this Kaplan-Meier study. And then coming to the randomized control trial versus starting from Dr. Bushnell, Delpasand from the Texas, then Kekebum from Netherlands, from Basel group 2006, Anthony from US 2. So there are 3 publications from US and 1 from Basel, 1 from Rotterdam. Rotterdam showed the best result and 30% objective response rate, and there was a median overall survival 46 months. But compared to the American, I don't know why 12% has got only 13.3 month median overall survival, which is that means he is treating very, very sick and very late stage patients. And you look at this Strasbourg, who works in the Moffitt Cancer Institute, had headed this trial, Letter 1. 231 patients randomized into the 117 and 114, lutetium arm people 18 and 3, whereas the long-term overall survival has got 11.7% increase overall control, overall increase over the control overall survival, but there was no statistical significant difference. I am coming to that. This is the interim result published in New England Journal, and the Lancet Oncology recently published the overall result. The overall result was not that exciting. You have already seen this is the trial. Up to this was the part 1, and now I'll show the part 2. Part 2, what happened? Why, if you have, there is a crossover study, normally overall survival cannot be properly analyzed, because the patient who are supposed to die is not going to die because they are given intervention. So that's why most of the crossover study will not able to show any overall survival, which is statistically significant, which is statistically a feasible possibility, and which has been actually proven here. You can see the curves, they go on merging with each other, and the statistically they are not significant. But what is significant? Whenever the whenever 95% CI cross 0, that is not significant. You can just look at the data. You don't have to look at it. You look at the 95% CI, it crossed to 1, so that means it is not significant. So these two data, but what was important is the 11.4 months, that is the improvement in the, and another interesting observation from this 5 years of study from the later trial, that there are only 2 patients out of 111 had myelodysplastic syndrome, which was very high with renal failure, myelodysplastic syndrome, acute myeloid leukemia or lymphocytic leukemia was with the yttrium 90 was not seen in the lutetium 177. The result is consistent, and coincidence is 3% previous lutetium. All other studies had shown 3%. No cases of acute myeloid leukemia are reported in letter 1, which is long-term outcome. Very, very satisfying, and very, very to the oncologist is very encouraging results. And then we have got the nephrotoxicity has been important safety consideration. PRRT, the rate of severe nephrotoxicity is only 5%, similar to the control 4%. So there was no statistical significance. Similar changes in creatinine clearance also similar. So there is not, so very, very satisfying and guaranteeing that the therapy is safe. The lutetium-dotated treatment did not significantly improve the median overall survival, as I told you, because there was a lot of crossover. So 1/3 to 1/4 of the patient had crossed over, so the overall survival will not be. But the 11.7 month difference in median overall survival with the lutetium-dotated treatment versus high-dose actinium, high-dose long-acting octreotide alone, accompanied by a favorable long-term safety profile, can be considered as a clinically relevant outcome. Then our experience from All India Institute, we have decided, you can see there are two, the Kaplan-Meier data, which is showing clearly, if you are combining a lutetium dotatate with a capecitabine, which is a radiation sensitizing agent, the results are much more better than comparing giving alone. Now, you know, in oncology, monotherapy rarely work. You have to give polytherapy, you have to add something which will be beneficial, which will have 1 + 1 is not 2, 1 + 1 may be 11. So in oncology, there is a multi-pharma is the rule of the day than exception. And then we have got the study using those patients who failed lutetium therapy. Is there any option? This is the study by the Kratuchil et al. In 2014 showed preliminary good result in 7 patients using bismuth dotatate that is targeted alpha therapy who had progressed on yttrium 90 and lutetium 177 dotatate. And this was only drawback that this was intraarterial administration. And because these patients, 6 out of the 7 patients, had liver mets only. There was no metastasis anywhere. So you can give, they thought if you give intraarterially through the hepatic artery, you can get better results. But you can get better results, but there is nothing to stop them to in the liver. The blood flow is universal. They will go immediately. What the chemotherapists they do, they put something gel fan, they stop the flow. But here there is nothing. So they will go immediately. So we quickly realize that intraarterial therapy is not the choice of the day, because if you want to bring it to the secondary level, tertiary level, or even to the primary level of therapy, to the small district hospital level, you need IV injection, not intraarterial, because you need an interventional room, then you need radiation protection, you need all permissions. The results were very encouraging. So this is what they showed is the partial response, and they showed complete response. This was the very encouraging result. But after reading this paper, we thought it is not a very good option. We should go for the intravenous. And this is our result. This was 7 patients. We did another 25 patients, and this was published in European Journal of Nuclear Medicine, broadening the horizon of actinium dotated therapy. Instead of going for bismuth, which has got a 46-minute half-life, you need a actinium bismuth generator, and you separate out. Why you want to change the generator? You give the actinium directly, so it will be a nano generator in the body, and that's what our experience. Those who failed lutetium, we tried to use them, and this was our results very, very encouraging. And this is intravenous, not intraarterial. So this unknown primary, you can see now completely disappearance, and this is published already in the literature. Then we have got actinium TAT. We had coming to the result, we could evaluate out of 24 patients, because we need at least 4 cycles. 15 patients had already completed 4 cycles, and the stable disease was in 37.5%, partial response in 62.5% patient. Results showed that actinium dotatate is a promising treatment option even in patients previously progressed on, that is 56% on lutetium dotatate PRN. Those who have progressed, they also responded very well. And this is what the 2021 Henry Wagner Award SNM says. Paul et al. From All India Institute of Medical Sciences in 82 patients, now increased to 82 patients, and we published, presented last year, and this was considered as the best presentation of the year. And this paper is under evaluation, maybe coming anytime soon. So coming to the any other actinium apart from the bismuth and actinium, any other, now the Dr. Ibrahim Del Pasant's group from Texas has come out with the lead 212, which is a dotamtate acetate, alpha therapy. And coming to that a little bit, what is this? This is just published in January this year. And the drug consists of dotamtate. If you coming back, it has got a lead as a radionuclide. Bifunctional chelate is dotam, and tate is the somatostatin receptor. So you need what is then coming back to the lead 212 has got 10.6 hour half-life, which has got 2 alpha emitters. One is by 36% from bismuth 212 decays to thallium 208, which in 3 minutes goes to the lead 208. And then other option is by 64% by beta emission go to polonium 212. Then polonium gives alpha 8.8 MeV. So we have got 6.1 MeV alpha, which is 36%, and we have got 8.8 MeV alpha, 64%. That concept. And if you contribution of equivalent dose, that the 97% comes from alpha, 3% comes from beta. So coming to the difference between DOTA and DOTAM, The the bifunctional chelate has got 4 acetic acid, tetrafluoroacetic acid, and if you join one hydroxyl group replace with a NH group, now this is glycine, this is the alpha carbon, this is the NH2COH, and one of these OH and undergoes a condensation reaction, forming water, removed waters and this nitrogen. So this forms a peptide. So this is called tetraglycine DOTA. Tetraglycine DOTA is called DOTA. And so you have got the same bifunctional chelate. You have got lead can be labeled with it, and I can show you next how the lead can. So now the final structures looks like this. A lead 212 labeled to the DOTAM, and the DOTAM is connected to the peptide ring, and then you can have this DOTAM TET. Is it TET? Coming to the design of the study, this is called single ascending, because they don't know what is the dose to be given. So you go by the single ascending dose, another is by multiple ascending dose. So you go by the multiple ascending dose, and the initial dose was 1.92 megabecquerel, that is 30 microcurie per kg, increased by 2.5 megabecquerel per kg, and the increment is 30, and you can go up to 24 millicurie. Here in the single ascending dose, they went up to 8 millicurie just to see which one is suitable. And interestingly, the multiple dose and higher activity was found better. So the 20-patient naive study in 10 male and 10 females, median age 62 years. 10 subjects, 100% received 4 cycles of lead DOTAM TET 1-2 therapy at the highest megabecquerel per kg per cycle, and then mean accumulative doses in 4 cycle was 21.4 millicurie. The time span between the histological diagnosis and the first cycle of treatment varied considerably between patients to patient, ranging from 0.3 years to 10 years. Mean is 5.3 years. So this was the result they have published in JNM, and it's a very nice cartoon showing that it's extensive disease, and there are 4 injections, and after DOTATOC, DOTATET, DOTANOC scan, so very, very nice complete remission. They had only one complete remission, so that they showed very nicely. They had only one complete remission in their series, and then they got very good. The median follow-up was 17.4 months. The duration of response is 14 months. Well tolerated with the mild and moderate side effects. Robust imaging data. Inclusion of subjects with progressive metastatic NET, regardless of location of primary tumor, and KI67 grade. Limitation is number of patients is small. Follow-up duration is limited. The lack of central imaging. They did that like in NET trial and other things, they are being central evaluation, so there is no central evaluation done. So to conclusion, lead 212 DOTAM TET is safe, preliminary efficacy are highly promising. If these results are confirmed in larger study, so it could be next. What are the future left with us? The radiolabeled agonist and antagonist for peptide receptor other than the somatostatin receptors are currently being investigated, like PAPI, might become available as therapy for carcinoid tumors, or in the drugs like pasireotide. List is going on. We have got VIP as a target, CCK2 as a target, Bombacin as a target, GRP receptor as a target. So we have huge targets. We have different designed probe, and India needs around 100 curie of high specific activity of lutetium per week to treat all the neuroendocrine tumors in this country. With this remark, I thank you very much to the organizers giving me an opportunity and discussing all these issues, which is very close to my heart. Thank you very much.
Thank you, Dr. Bal, for a nice presentation. Whatever we had the questions, it's all answered, like CAPTEM and the use of new traces like lead and actinium, your experience. Thank you so much. So if any questions are there, please ask.
I hope I have clarified many things which they are supposed to. Otherwise, you can ask me anytime. No problem.
Sir, I would like to ask, like, what are your views on SSTR antagonists? Like, many papers are coming which are saying that it's looking more effective than whatever that you are using right
my
now.
girlfriend is better than your girlfriend. There is no one-to-one comparison. There is no one-to-one comparison. It's just saying that you have a molecule, you want to push it. But if you want to compare a new molecule, you have to compare against a standard of care molecule. That is what FDA or any regulatory authority has to say, that if A is already equal to B, why should B given approval? Unless The B has got the cost less, convenience of treatment, side effects are less. It's called equivalence fat. When you do the same drug and showing equally effective, then you need to prove that there is some positive effect, even they are equally good.
Dr. Paul, I have a quick question for you.
Sure.
For lutetium patients who have recurrence or progression of disease after the 4 cycles of lutetium therapy, do you give additional lutetium therapies or do you go with FD?
We have called a re-challenge lutetium octreotide therapy option, and those who can go for that, we gave them a re-challenge, and we have gone up to 12 cycles, not the letter 4, and we have gone up to 12 cycles also. But we give them option that if we think your disease is very aggressive and is not behaving well, you have another option. We can go for the alpha therapy. And then we explain them if they can pay the cost, because it's not like insurance, it is paying from the pocket. If some people are putting, now we have more than 200 patients treated with alpha therapy, more than 200 patients.
Sir, how
That's
often
great.
you
One
do
more thing.
FDG? Sorry.
Yeah, go ahead.
So how often you do FDG scans for the patients planned for lutetium therapy? Is it like baseline only, or in between if there is any clinical
No.
suspicion?
In between we don't do. Most of the time the patient comes to us because now FDG, once upon a time they like MR. Any patient comes to the hospital had already a MR scan done, because people thought if we enter your head inside the MR, the diagnosis will be written and come out. So now PET is going to the same page. So anybody is sick, they ask for a FDG PET scan, including पेट में दर्द है, some tumor, neurological so you can have justification saying no, I am looking for a paraneoplastic syndrome. You can get a FDG PET scan there. So this is type. Most of the time that patient they come, because from all over country the patient to come to me. So I see them most of the time the FDG is done. If there is already done, I don't do, or subsequently I don't do. If there is no FDG uptake in the to start with, unlikely to later take off. So if they respond, so what do? I do a gallium dotanox scan to identify map the disease, the extent of disease, the uptake pattern, the SUV max, and then I treat. And after 3 cycles, I repeat the FDG, I repeat the dotanox scan to see the response. So we don't go by the chromogranin only, we do the dotanox scan as interim analysis. If the patient has not responded, rather progressed, we stop. If the patient has stable or improved, we continue with the cycles. Unlike Americans, they give 4 cycles, we have gone up to the 9 to 12 cycles. Because they are the FDA will not allow you after 4 cycles, will not know reimbursement. It's already
Right.
$200,000.
Right. We have done additional cycles in a few patients, about 5 or 6 of them.
Yeah.
And we have done additional 2 cycles of lutetium therapy.
Yeah.
And what is your experience with usual recurrence or progression of disease after lutetium therapy? Because since you have done such a huge number over so many years, it would be interesting to know how many patients have you seen, who have progression after lutetium, and after usually how long a duration after the therapy?
To be honest, our patient in India, as you know, you must be knowing, they are Indian patients, they come out very late. The disease is not in grams, in kilograms. And most of the patient eventually they will die. Now in 14 years time, my longest surviving patient is 14 years and is a professor in IIM Calcutta. So he has survived 14 years, and the last few months back he developed MDS. And that's what in 14 years he has survived. He had gone back, he came on wheelchair, he improved, he went and joined back, retired from his job. Now he has developed MDS. So similarly, what eventually they will all die. Only thing that what we are improving their quality of life, we are there increasing quality of life, and we are improving their stable disease is also a good achievement. Most of the time we get partial response. Complete response occasionally we get. To be
Yeah,
very
I would
honest.
say, even symptomatic relief is also a
Yeah.
big thing for these patients.
It's out of 111 patient in NET trial, only one patient got complete remission. But
Right.
you look at the European group data, particularly Dr. Richard Baum's data showing 30% complete remission, all this. You know what, I don't have to pronounce in this gathering.
Right, right.
Yeah, you know what I do also. I don't want to announce that.
No, you have more experience than I have.
And
especially with the
one
number
of the SNM meeting, he was trying to market this. I stood up and I told the Dr. Baum, this is not the result we see in India. No, you must be giving lesser dose, you must this, that. But how now NETR trial has validated what we have been all the time telling.
Mhm.
In science, if you do in the correct way, whether it is done in New York or it is done in New Delhi or it is in the Eastern, they will have same result. But if you try to sell your product, then you can have all sorts of gimmicks. My brush is better, नचकदार है, आपका brush hard है, आपका gum damage करेगा वो marketing gimmicks. I don't believe in. I'm a pure academician.
Yeah, I fully agree with you. And you know what I have been seeing over the last 4 years that we have been treating, that whenever there is progression of disease after lutetium in most patients, in some of the patients that we have seen, has happened usually after a couple of years of.
Yeah, correct. Very correct.
That is the usual timeline that I'm seeing in
Yeah.
most of the patients that we are treating. And I think we have 5 or 6 patients who we have given additional therapy. A couple who were being planned had to be sent to hospice because they decided.
Yeah, sure.
So regarding one patient, young patient with a metastatic paraganglioma, that patient FDG is positive and DOTA is positive. So we are giving lutetium and the clinician is not confident to give chemotherapy because the pathologist says it's a well differentiated thing. So
Yeah,
what do
correct.
you say?
In that patient, please add capecitabine.
Pardon?
Add capecitabine.
Yeah, that's
This
what
is
we feel
oral
that the
5
pathology is less than 2%.
We have recently published a paper on with paraganglioma showing with the capecitabine and without capecitabine results are remarkably different. So in oncology, monotherapy is very rarely done. We have to have we are still in the evolving phase. There is a combination therapy. We need whether some people are trying to use the captem, temozolomide, capecitabine with the radionuclide therapy. Some sort of combination is going on, and I am sure in next few years' time, the big pharma company will sponsor those type of trials. Of course, they will have interest in selling the drugs also. So then they will be bringing it down. But our own experience is that when we give capecitabine, we give the curves start separating out very well.
But pathology says well differentiated, less than 2%.
No, here we are giving capecitabine not as a chemotherapy, as a radiosensitizing agent. So we keep only 2 grams, and that's only for 2 weeks.
Sir,
Because 2 half-life of lutetium, 7 days, 2 half-life, we keep only up to 14 days capecitabine and lesser dose, not like the chemotherapy dose.
I think the same thing will be applicable for GEP-NETs also, right, sir? Metastatic
Yeah, we are
GEP-NETs.
I told you that paper I showed you. That is GEP-NET. We have also done for the paraganglioma that is coming this month of EJNM. You'll see in the April issue of EJNM, you will find that paper. Already I have done the correction, proofreading, and they will be publishing online anytime. So the paraganglioma, if you give the capecitabine as a radiosensitizing agent, your effect is much better.
Do you think there will be any added advantage of adding radiosensitizer in alpha therapy?
In alpha therapy, you have seen that curve. Now, alpha therapy doesn't depend on what well differentiated and not differentiated. O is like putting a atom bomb. That will not see whether your building is a 10-story or 5-story or 2-story. It will just boom, finished. So alpha has no oxygen enhancing effect. It doesn't believe on anything. It just go and finish the job.
So alpha therapy is the rampant.
Yes, that is but there is not much of alpha. Americans did the mistake. They put tons of the radionuclide waste after the Cold War in somewhere in the Fiji, some seabed in Fiji. They have lost the tons of dollars. These are all the nuclear waste which are used for making the separating out the along with the baby, along with the bath water, you throw the baby.
Then, we are not doing any alpha therapies. They are not FDA approved at this point. They are still,
But this Dr. Delpasand, Ibrahim Delpasand is from Texas only. He published the Alpha 2 and 2. Then your Memorial Sloan Kettering people are also using for acute myeloid leukemia. We are a part of that trial also. We are there trying to hook us because we have a lot of experience with alpha. So now there is a company which is combining our experience, our site and Memorial site to for the next for acute leukemias.
And it was really great listening to you and learning so much from you. And I think we'll keep in touch, and I'll need to learn more about alpha therapies with all your experience. And I know Dr. Bachu has been doing some alpha therapies down at AIG. So that will be the area that we would like to move forward. I think thanks for all the insight, and it was a great
Before this pandemic, we used to treat 30 patients with alpha per month. 30 patients.
That's a huge number.
Sir, what is your experience in FAPI, particularly for midgut entities, where we know that desmoplastic reaction is high?
Yeah, you can, but what my interest is, you see, the FAPI is a molecule which is only limitedly available. It's not being commercialized.
Yeah.
The Heidelberg group has put the patent file. So as usual, the Chinese have now grey market FAPI available all over world have been flooded with the grey market FAPI4. But then when you send it for publication, you have to disclose the structure and where you got it. So that's why, but unfortunately, we have a collaboration with the University of Mainz in Germany, and Dr. Frank Ross is our collaborator. He's a chemist, and we are the clinical side. So we develop the drug, he does the animal study, then after the animal study data available, we do the clinical trial, and that's why we have in the January issue of Thyroid, the ATA official journal has got cover page from our side. After 80 years, in thyroid cancer, there is a new radionuclide therapy available for radioiodine refractory thyroid cancer. That has come as a proffered paper, and the image has been pushed on the cover page of Thyroid. 13-page article. This is our first experience, and we have now going to have a longer experience and larger number, and expanding the series to put it in a bigger journal, Oncology journal. We are planning.
And I fully agree with you. Theranostics is the area which is going to expand, and now we are getting more and more approval of drugs, both for diagnostics as well as therapies. So I think
you can look at the JNM. You just open up the JNM issue, can find 80% is now therapy and 20% because the FDG era is over. Now the radiologists want to take it to their domain.
Correct. I agree with you. So that's a very positive thing for us. I think we have waited long.
Because they are not interested. The radiologists are not interested in therapy. That is a good thing for us.
Yeah, here the treatment is here the training is very different.
Yeah.
And I think it will be at some point it will be nice to discuss about the future of nuclear medicine as well as the training of programs, how it happens in different countries.
Dr. Manoj, you will be happy to know that we are the first people in the world to start a 3 years therapy DM program, which is equivalent to your fellowship. 3 years therapy program, fully dedicated therapist. I am creating from 2016 onwards.
I think I might have to start thinking about coming to you and doing the therapy program.
3 years dedicated in therapy is a very unique challenge.
I agree.
Because you have to understand dosimetry, you have to understand the sequencing, you have to understand the paradigm, how you, if you are giving chemotherapy along with these drugs, what are their side effects. And you know, I treat more TKI than our medical oncologist in all India. I prescribe more TKIs.
One last question. How commonly are you using beta therapy as a de novo compared to sandostatin, sir? Are you using it routinely in metastatic cases, or you start with?
You will see our paper. We have now already 27 patients who had started with the de novo. They have never received any sandostatin.
Oh, okay.
If you read the PROMED trial, The total population was 92 and 45 each arms, and they told that sandostatin has got anti-neoplastic effect, and the company pushed it, and nobody has got tons of money to push it, and they got it approval. Now everybody, because all the medical oncologists had nothing to do with the neuroendocrine, now they say, okay, we give sandostatin, one injection in a month. And after 10, 20, 30 months, they get fed up. The patient get also very angry. Every month, aap aate kuch bhi nahi ho rahe. And then the patient goes somewhere, get a scan done, saying, oh, the tumor to badh gaya. Now they send to us.
Okay.
Thank you so
Thank
much,
you,
Dr.
sir.
Manoj and Dr. Bal, for nice presentation. Hope the audience enjoyed the talks from a clinician, pathologist, and also from nuclear medicine physicians. Thank you so much.
Thank you. Have a great day.
Thank you.
Thank you, one and all.